Magandang umaga po. Ako po si Carlos Mendoza, second year medical student. At ako po ay magtatanong ng mga tanong tungkol sa bisita niyo dito.
Okay, sige.
Okay. Unang-una po, ano po pangalan niyo?
Carla,
Carla. Ilan taon na po kayo?
26.
Kailan po kayo pinanganak?
March 26, 1993.
Saan po kayo nakatira?
Sa Santa Rosa, Laguna.
Kayo po ba ay kasal na?
Hindi pa.
Hindi pa. So wala pa kayong anak?
Wala pa.
Okay. Ano po ang iyong relihiyon?
Katoliko.
Ano po ang iyong trabaho?
Wala. Nag-aaral.
Nag-aaral. Ano po ang problema at nandito po kayo?
Masakit yung tiyan ko.
Saan po masakit?
Dito sa may baba.
Kailan po nagsimula?
Nung isang araw.
Ano po ang klaseng sakit?
Parang humihilab siya na masakit.
From 1 to 10 po, gaano po kasakit? 1 bilang hindi masakit at 10 bilang sobrang
Mga
sakit.
6.
Ano po ginagawa nyo upang mabawasan ng sakit?
Wala. Humihiga lang. Tapos umiiyak. Kasi masakit.
Ano pa po ang nararamdaman nyo?
Yun lang naman. Parang nasusuka pero pakiramdam lang.
Tuwing kailan po sumasakit at ano po ginagawa nyo tuwing sumasakit?
Wala eh. Bigla lang siyang sumasakit.
May iniinom po ba kayong gamot para
Wala.
mabawasan po yung sakit? Kailan po kayo huling nagkasakit?
Nung May.
Kayo po ba ay na-confine na? Ano po ang dahilan pagka-confine?
Dengue.
Kayo po ba ay naoperahan?
Hindi pa.
Kayo po ba ay may diabetes?
Wala.
Diabetes?
Meron.
Ika?
Wala.
High blood?
Wala.
Nung bata po ba kayo, nagkabulutong na kayo?
Matanda na ako nagkabulutong.
Tigdas?
Hindi pa.
Beke?
Oo. Bata.
Nung bata po ba kayo, kumpleto po ba ang iyong bakuna?
Oo.
Kayo po ba ay may allergies?
Wala.
Natatandaan niyo po ba kailan kayo unang niregla?
Oo. Nung 10 years old.
Kailan po kayo huling dinatnan?
Last week.
Kayo po ba ay regular o irregular?
Regular.
Ilan pong napkin ang nagagamit niyo sa isang araw?
Mga 6.
Sumasakit po ba ang iyong puson tuwing nagkakaroon kayo? Kayo po ba ay nakikipagtali?
Oo.
Tuwing nakikipagtalik kayo, gumagamit po ba kayo ng pills o condoms?
Oo.
Kayo po ba ay may anak na?
Oo, wala.
Nahihirapan po ba kayo umihi?
Hindi naman.
Kayo po ba ay nagka-infection sa maselang bahagi?
Hindi.
O UTI? May iniinom po ba kayo na gamot?
Meron.
Araw-araw niyo po ba iniinom?
Oo.
Para saan po ang gamot?
Para sa diabetes.
Vitamins, iniinom po ba kayo?
Wala.
Ang pamilya niyo po ba may sakit tulad ng cancer, diabetes, hika o high blood?
Oo, meron.
Kamusta po ang iyong mga magulang?
Okay naman.
Malusog po ba sila? Buhay po sila? Ilan kayo magkakapatid?
2 kami magkapatid.
Kamusta po ang kapatid niyo?
Namatay na yung kapatid ko.
Ilan taon siya namatay?
21.
Ano po ang kinamatay?
Na aksidente.
Kayo po ba ay kasal na? Gano'n na po kayo katagal?
Mga 5 taon na.
Kamusta po ang mga anak niyo?
Okay naman.
Masigla po ba sila? Malusog? Ano po trabaho niyo?
Ngayon, sa bahay lang kasi buntis ako.
Sa bahay, ano po pinag-aabalahan niyo?
Wala, linis-linis ng bahay, gagawa ng homework ng mga anak ko.
Kayo po ba ay umiinom ng alak o nag-iossi?
Umiinom ako dati nung hindi ako buntis. Pero hindi ako naninigarilyo.
Mga ibang droga?
Siyempre hindi.
Sige po, salamat po. Thank you.
Okay, thank you.
Hello, I'm Dr. Samuel John Albaida Basilio. I'm here to do the vital signs. So the first part of the vital signs that we're supposed to do is the history taking, which was done earlier. So I'm gonna skip that. Next, we have to look at the general survey, wherein we have to look if the patient is, we have to look at the apparent state of health of the patient, if the patient is acutely ill, chronically ill, frail, robust, vigorous. Then we have to check for the level of consciousness of the patient, if it's ALOSC, which is A for alert, L for lethargic, O for obtunded, S for stupor, and C for coma. Then after that, we look for signs of distress, wherein it could be cardiac or respiratory distress. If the patient is clutching his chest, that could be known as the Levine sign. If the patient has pallor, diaphoresis, labored breathing, wheezing, or cough. Then next, we check for pain. If the patient is wincing, sweating, or protecting a painful area. And we check also for anxiety or depression. We look at the patient's face. If the patient appears anxious, we check for fidgety movements. We check for cold and moist palms, inexpressive or flat affect, poor eye contact, and psychomotor lesions. Next that we check in the general survey is the skin color and obvious lesions. We check for the dress, grooming, and personal hygiene. And we also check for the facial expression, body odor and breath, posture, gait, and also motor activity. Next that's checked in the vital signs is the height and weight of the patient, wherein we would measure the height and the weight, and we'll check for the BMI of the patient, which is weight in kilograms over height in meters squared. So next we do is the blood pressure. I'm gonna run you through how to take the patient's blood pressure. Hello, good evening. I'm Samuel Jacob Baida Basilio. Ako po yung doctor niyo po ngayong araw. Ano pong pangalan niyo? Ariel Lee. Okay, kamusta naman po kayo, Miss Ariel?
Okay naman po.
Nagkape po ba kayo bago pumunta dito?
Hindi po.
Puyat po ba kayo?
Hindi po.
Kumain po ba kayo bago pumunta dito?
Hindi po.
Okay, sige po. So dahil doon, kukunin po namin ngayon ang inyong blood pressure. So, pakiayos po ang upo. Sit straight back, relax. Feet flat on the ground. Ngayon yung arm nyo, i-level natin dito at the level of your heart. Please remove any watch or bracelets para hindi ma-affect yung inyong pag-take ng blood pressure. Slightly flex your arm at the elbow. Put it like that. Since nakaayos na po kayo, we'll be putting your sphygmomanometer cuff on top of your arm. Can you move your shirt upwards so that hindi affected yung sound? So, relax lang. So, now I'm gonna put the sphygmomanometer cuff on your arm, at least 1 inch or 2 fingers length away from the antecubital crease or the line, with the center area above the brachial artery. So we have to make sure na the BP cuff is snugly fit. On top. So okay naman. Have to check with 2 fingers if it's too tight or too loose. It's in good position now. Then first, we're gonna show how to do it via check the systolic blood pressure via palpation. So first we do is find the radial artery or the radial pulse from the radial artery. Once you find it, we're gonna inflate the cuff until the radial pulse disappears. Now since the radial pulse disappeared, we're gonna add 30 millimeters mercury to it. Then slowly release it until the radial pulse comes back. So the systolic blood pressure when I checked here was 120. So now we're gonna redo it this time with via auscultation. How's wrong? So, can you put it back? And put your shirt on. So now, I'm gonna place the cuff above the antecubital crease, at least 1 inch above, or typically 2 fingers length away from the antecubital crease, and the center area between the 2 ducts or tubes, whatever, directly above the brachial artery. So now, since it's gonna be done via auscultation, we'll put on our stethoscope the proper way, and we'll put the bell of the stethoscope in between or on top of the brachial artery. So from there, we're gonna start measuring. Looking for the systolic blood pressure. The systolic blood pressure will be the first place where the Korotkov sound sounds. Mali pagkalagay ko. And now we're gonna check for her blood pressure via auscultation. So that means we're gonna use a stethoscope. And the way you wear a stethoscope should be the proper way, which is where the curvature of the stethoscope is here, it should follow with the curvature of your ears. So now we're gonna use the bell of the stethoscope. We're gonna put it on top of the brachial artery. And since we're using the bell, because the bell is for for hearing the higher sounds, which is the Korotkov sound. So what we're gonna get here is for the systolic blood pressure, that would be the first Korotkov sound. Korotkov sound. We're gonna start. So now that we found the the systolic blood pressure, we're gonna measure it. We're gonna add 30 millimeters mercury to it, then slowly release it. As we slowly release it, the last Korotkov sound, that would be your diastolic blood pressure. Now that we've got your blood pressure is 120/80. So now we're gonna measure for the heart rate and rhythm of the patient. So with the pads of your fingers, your pointing finger and your second finger, or your pointer finger and your middle finger, the pads of these will be used to measure for the radial artery, the pulse of the radial artery, where you would compress the radial artery until you detect maximal pulsation. And you will count the pulsations. If there is regular rhythm, then count for 15 seconds. Count how many pulses there are within 15 seconds and times it by 4 for regular rhythms. If the rhythm is unusual, then you have to measure it for 60 seconds and assess the regularity of the pulsations. Next that should be done is the measurement of the patient's respiratory rate and rhythm, which could be done in conjunction with measuring for the heart rate. In doing this, after measuring the pulse, you just continue to check the patient's chest for its rise and its fall, so that you can observe the rate, rhythm, depth, and effort of breathing of the patient. The normal findings should be 14 to 20 breaths per minute. So that the patient wouldn't be conscious about his or her breathing, you can do it right after you count the pulse. So just pretend that you're still counting the pulse but in effect you're actually observing and counting for the respiratory rhythm. In doing the general survey of the patient, you first check for the patient's apparent state of health, wherein you check if the patient is acutely ill, chronically ill, frail, robust, or vigorous. Then the next thing to check is for the patient's level of consciousness, wherein you're going to use the abbreviation ALOSC, wherein A is for alert, L is for lethargic, O is for obtunded, S is for stupor, and C is for coma. So the next thing you check is for signs of distress. If the patient has cardiac or respiratory distress, things you would see are the patient is clutching his chest, which is called Levine sign. The patient has pallor, diaphoresis, labored breathing, wheezing, or cough. Next to check in signs of distress is pain. You would notice that if the patient is wincing, sweating, or protecting the painful area. Next to check is anxiety or depression, wherein the patient would have an anxious face, fidgety movements, cold and moist palms, inexpressive or flat affect, poor eye contact, and psychomotor slowing. So the next to check in your general survey is skin color and obvious lesions, dress, grooming, and personal hygiene, the facial expression of the patient, odors of body and breath, and last to check is the patient's posture, gait, and motor activity. So after that, the next thing to look at in the general survey in vital signs is the patient's height and weight, so that you can compute for his body mass index or his BMI. To do the BMI, you would have to measure the patient's weight in kilogram over the patient's height in meters squared. So the possible findings in measuring the patient's BMI is, if the patient has normal weight, as an Asian, it would be 17.5 to 22.99. But in worldwide, it is 18.5 to 24.99. Those are the normal values for Asian and around the world. So the patient would be underweight if the Asian patient would be underweight if his BMI would be less than 17.5. If the patient is overweight, he would be from Asian patient is overweight, it would be from 23 to 27.99. And if the patient is obese, he would have a BMI score of greater than 28. So next that we do is we check for the patient's blood pressure. So technically 2, 3. So now in checking for the patient's blood pressure, of course you would ask the patient questions like if they nagpuyat ba sila the night before, kumain po ba sila bago magpa-BP, or if nag-coffee ba sila, because coffee could raise the patient's blood pressure. So you have to position the patient properly, check if they're sitting properly, the feet should be flat on the ground, no cross legs or whatever bendy positions. So in the arm when you're gonna check for the BP, you have to make sure that they're not wearing their watch or any bracelets, and you have to make sure that they don't have any fistulas, scars, or lymphedema in that area. So you have to position the cuff at the arm. Arm should be at heart level. You should center the bladder over the brachial artery. Lower border of the cuff must be 1 inch or 2.5 centimeters above the antecubital crease. You have to slightly flex the patient's arm at the elbow, and the cuff must fit snugly. You should be able to put 2 fingers inside properly. So the first way to get the systolic blood pressure is by palpation. You have to palpate the radial artery while inflating the cuff until the radial pulse disappears. Then, from there, you have to read the pressure and add 30 millimeters mercury. So the next step to get the systolic blood pressure, or technically the whole blood pressure of the patient, is by auscultation, wherein you have to place the bell of the stethoscope on top of the brachial artery. And you have to inflate the cup rapidly to the level of the systolic blood pressure. Then you would add 30 millimeters mercury. Then you have to deflate it slowly, 2 to 3 millimeters mercury per second. The level where you first hear the Korotkov sound, or the first Korotkov sound you hear, that's going to be your systolic blood pressure. As you continue to lower the pressure, the disappearance point, or the last Korotkov sound, would be the diastolic blood pressure. The reason why we use the bell of the stethoscope is because the bell could hear the higher sounds, i.e. the Korotkov sounds. So, some additional things to know about taking blood pressure. You have to wait for 2 minutes, then you have to get the BP again to get an average blood pressure. Then you have to take both BPs in both arms at least once. So, some things to note: the length of the cuff is 80% of the upper arm circumference. The width of the cup is 40% of the lower arm conference, the upper arm conference, I mean. So 80-40. So possible findings: the normal blood pressure should be less than 120 to should be 120 over 180 diastolic. So the possible findings for blood pressure are, the normal findings in blood pressure are, should be less than 120 systolic or less than 80 diastolic. When the patient is pre-hypertensive, the findings should be from systolic 120 to 139, or in diastolic 80 to 89. If the person has stage 1 hypertension, the findings in the systolic BP would be 140 to 159, and in the diastolic BP it would be 90 to 99. In stage 2 hypertension, the systolic BP would be greater than or equal to 160, and in diastolic it would be greater than or equal to 100. In diabetes or renal disease, the BP would be less than 130 and less than 80 diastolic. So the blood pressure is in millimeters mercury. So some abnormalities to take note in taking blood pressure would be white coat hypertension, which is the blood pressure is high when you see the doctor, even though your blood pressure is normal. It's just like you're afraid of the doctor, so your blood pressure would go up when you see him. That's why it's white coat. And there's masked hypertension, wherein you have abnormally high, you have a high blood pressure, but then since you're conditioning yourself when you go to the hospital, since you know you're gonna take the blood pressure, your blood pressure normalizes. So that is masked hypertension. Then of course, hypertension, which is high BP, hypotension, which is low blood pressure, and orthostatic hypotension, wherein 20 millimeters mercury drop in systolic blood pressure and 10 millimeters mercury drop in diastolic blood pressure when you stand. Then there's a thing also as nocturnal hypertension, wherein the blood pressure dips as they shift from wakefulness to sleep. So things to note when taking the blood pressure. You have to check the BP on both arms at least once. Difference must not be greater than 10 millimeters mercury. If it is greater than 10 millimeters mercury, then the patient might have atherosclerosis, subclavian artery disease, coarctation of the aorta, or aortic dissection. Then, when checking the ankle brachial index, BP on the dorsalis pedis, or the posterior tibial artery, over the BP in your brachial artery, that is your ankle brachial index, or ABI. The normal is, the difference should be 0.9 to 1.3. If greater than 20 millimeters mercury at the leg over the arm difference, then the patient might have chronic severe aortic regurgitation or peripheral artery disease. So heart rate and rhythm. With the pads of your fingers, you have to compress the radial artery in your hand until you detect the maximal pulsation. Then you count the pulsations. If the patient has regular rhythm, then you have to count the pulsations within 15 seconds, then multiply it by 4 to make it quicker. If the patient has unusual rhythm, Then you have to count the pulsations within 1 minute or 60 seconds. Then you have to assess the regularity of the pulsations. Some possible findings: the normal pulse rate or heart rate and rhythm is 60 to 90 to 100 beats per minute. So when you check the rhythm, of course there's the normal with rhythm, then there's small weak pulses, large bounding pulses, Bispherians pulse, pulsus alterans, bigeminal pulse, and paradoxical pulse. So next to check is the respiratory rate and rhythm. To check the respiratory rate and rhythm, so that the patient won't try to improve his breathing and would just breathe naturally. The technique that physicians use and people who check use is while checking the radial pulse, they would pretend to continue to keep counting, but they're actually observing the chest of the patient while doing that. So what they observe is the rise and fall of the chest so that they can count the respiratory rate. So what you check when you do the respiratory rate and rhythm is the rate, the rhythm, the depth, and the effort of breathing. So count number of respirations in 1 minute either by visual inspection or by auscultation of the trachea. So possible findings: the normal values in adults for your RR is 14 to 20 breaths per minute. In infants, it's 44 breaths per minute. The abnormalities that you can find in the patient's RR is bradypnea, sighing respiration, tachypnea, Cheyne-Stokes breathing, hyperpnea or hyperventilation, obstructive breathing, and ataxic/biot breathing. So when checking the temperature of the patient, you can check the oral, rectal, or axillary temperature. So possible findings: the oral temperature would be 37 degrees Celsius, rectal temperature would be higher by 0.4 to 0.5 degrees Celsius as compared to your oral temperature, and your axillary temperature would be lower by 1 degree Celsius. So in abnormalities, if the temperature is too high, you can have fever, hyperpyrexia, or if it's too low, hypothermia.
Magandang araw po, ako po si Maeve, second year medical student. Ay, examine ko po kayo ngayon sa inyong puso. Unang pong gagawin natin is iti-take ang inyong BP. Kamusta naman po kayo ngayong araw?
Okay naman.
Kung uminom po ba kayo ng caffeinated drinks bago kayo dumating dito? Coke, kape?
Wala lang.
Wala. Hindi naman po kayo puyat?
Hindi po.
Hindi po kayo nag-yoski?
Hindi po.
Okay. Okay naman po yung pakiramdam niyo overall?
Opo.
Sige po, relax lang po yung upo natin. Pati po, pakitaas na lang po yung mangas ninyo. Feet fat on the floor. So there must be no fistulas, woods, lymphedema on the side of the arm where you will take the BP. So place the BP cuff around the arm. Not too tight and not too loose. So the lower border must be above the decubital crest, 1 inch or 2.5 centimeters. So first is you're going to get the systolic blood pressure by palpation. First, you get the systolic blood pressure by palpation. Para po mapabuti ko pong malaman ng yung BP, check ko lang po yung systolic blood pressure nyo. Relax nyo lang po yung kamay nyo. Okay. Palpate for the radial artery while inflating the cuff until the radial pulse disappears. Okay, your systolic blood pressure is 130 mm mercury. You'll have to add 30 millimeter mercury so that would be the baseline for getting the blood pressure to avoid a auscultatory gap. After getting the systolic blood pressure, we go now to getting the blood pressure by auscultation. First, you place the bell over the brachial artery underneath the cuff. Then inflate the cuff rapidly to the level of systolic blood pressure and add 20 millimeter mercury. After that, you should deflate the cuff slowly by 2 millimeter mercury per second. So the patient's blood pressure is 120/80, which is normal. Okay lang po bang humiga kayo dito at check lang po yung ugat niyo sa leg? Okay, tanggal na din po yung shirt niya. Okay, raise the head of the patient to about 30 degrees. Turn the patient's head slightly away from the side you are inspecting. Pwede po bang tumingin kayo sa gilid? Use tangential lighting and examine both sides of the neck. So here you will see the internal jugular vein just posterior to your sternocleidomastoid. And posterior to your internal jugular vein is your external jugular vein. Pwede pong tingin po kayo sa kabilang side. Examine the other side, see for the internal and external jugular vein. Okay. Let's focus on the right internal jugular vein. Tingin po ulit kayo sa akin. Okay lang po bang may hawakan ako dito sa dibdib mo sa bandang taas?
Sige po.
So look for the sternal angle of Louis. And please, a ruler on top of the sternal angle of Louis. So look for the highest pulsation of the internal jugular vein and make a right angle connecting to the ruler on top of the sternal angle of Louis. So make a right angle. Okay. Measure the vertical distance in centimeters above the sternal angle where the horizontal object crosses the ruler. So the JVP is 2 centimeters above the sternal angle of Louis at an elevation of 30 degrees.
Yeah.
Next is for the palpation. Okay lang po bang hawakan ko po ang inyong dibdib para i-check ko lang po kung may abnormal sa pagtibok ng puso niya. Palpate in the second right intercostal space, which is the aortic area. Hindi naman po masakit. Palpate on the second left intercostal space, which is the pulmonic area. Hindi po masakit. Palpate along the sternal border, which is the tricuspid area. Hindi po masakit. And palpate on the apex, which is the mitral area. Hindi naman po masakit. Okay lang po bang hawakan ko ang inyong chan dito sa bandang kanan para po medyo didiinan ko lang po for 10 seconds. Tingin po kayo sa gilid. After that, measure the JVP right away. So the JVP after the hepatojugular reflex is 3 centimeters. Next, we're going to palpate for the extremities to check for edema. Okay lang po bang kapain ko po ang inyong mga braso at mga binti? So the patient's extremities are not edematous. For the last part, we'll do the auscultation. Ngayon po, papakinggan po naman. Ayan, Okay, ulit. 1, 2, 3, go. For the last part, we'll go to auscultation. Ngayon po, papakinggan ko naman po ang inyong puso. So, position the patient properly. Identify the auscultatory areas, the aortic area, which is located at the right second intercostal space. Hinga pong malalim. And the pulmonic area, which is located at the left second intercostal space. Hinga pong malalim. Tricuspid area. And the mitral area, which is the apex. Do the auscultation using the diaphragm and the bell. So you repeat it using the bell. So the S1 splitting is heard on the tricuspid area, and the S2 splitting is heard on the pulmonic area. S1 and S2 are crisp, with S1 louder at the apex and S2 louder at the base. There are no murmurs or extra hard sounds. Okay, thank you po. Pagalit po kayo. So in examining the patient's cardiovascular system, you must first introduce yourself to the patient and let the patient know what you will do. The first part is getting the blood pressure. So ask the patient if he had drunk caffeinated beverages, smoked cigarettes, took any meds, or if he had enough sleep before getting examined. Let the patient sit comfortably with feet flat on the floor. Ask the patient to remove watch or bracelets on the arm to be examined. So there must be no fistulas, wounds, lymphedema on the side of the arm that we're going to inspect. So position the cuff and arm properly. So the arm should be at the heart level. Center the bladder over the brachial artery, and lower border of the cuff must be 1 inch or 2.5 centimeters above the antecubital crease. Slightly flex the patient's arm at elbow. The cuff must fit snugly, not too tight or not too loose. At least 2 fingers must fit through the space. So first, get the systolic blood pressure by palpation. Palpate the radial artery while inflating the cuff until the radial pulse disappears. So read the pressure and add 30 mm mercury. So after getting the systolic blood pressure, get the blood pressure by auscultation. Place the bell of the stethoscope over the brachial pulse underneath the cuff. Inflate cuff rapidly to the level of the systolic blood pressure and add 30 mm mercury. Then deflate it slowly by 2 mm mercury per second. The level where you first hear the broad cuff sound is the systolic blood pressure, and then continue to lower the pressure. The disappearance point is the diastolic pressure. So additional note is that you have to wait 2 minutes, then get the blood pressure again, and then average the 2 blood pressures. So you must take blood pressure in both arms at least once. So again, length of the cuff is 80% of upper arm circumference, and the width of the cuff is 40% of the upper arm circumference. Also, you must know the blood pressure numbers to indicate if the patient is hypotensive, hypertensive, or have a normal blood pressure. Next is to get the jugular venous pulse. Make the patient comfortable. Raise the head slightly on a pillow to relax the SCM muscles. Next is to raise the head of the bed or examining table to about 30 degrees. Turn the patient's head slightly away from the side you are inspecting. Use tangential lighting and examine both sides of the neck. Identify the external jugular vein on each side, then find the internal jugular venous pulsations. Focus on the right internal jugular vein. Look for pulsations in the suprasternal notch between attachments of the SCM muscle on the sternum and clavicle, or just posterior to the SCM. Distinguish the pulsations of the IJV, or the internal jugular vein, from those of the carotid artery. So, once you have identified the highest point of pulsation, the right jugular vein, extend a rectangular object or card horizontally from that point and a centimeter ruler vertically from the sternal angle, making an exact right angle. Measure the vertical distance in centimeters above the sternal angle where the horizontal object crosses the ruler. So the possible findings are the normal JVP is less than 3 centimeters. In patients with obstructive lung disease, the JVP can appear elevated on expiration, but the veins collapse on inspiration. So this finding does not indicate heart failure. So you should report the JVP as the JVP of the patient is 2 to 3 centimeter above the sternal angle of Louis at an elevation of 30 degrees. Okay, inspection and palpation. Next is to inspect the anterior chest. So, careful inspection of anterior chest may reveal the location of the apical impulse, or PMI, ventricular movements of a left-sided S3 or S4. So you should shine a tangential light across the chest wall over the cardiac apex to make the movements more visible. So keep in mind the anatomic locations. The right second interspace is your aortic area. The left second interspace is your pulmonic area. The right ventricular area is located at the left sternal border. And the epigastric area is your subxiphoid, and the left ventricle area is the apex. So you should note the presence of a dynamic precordium, the shape of the chest, which can be barrel chest, kyphosis, straight back, pigeon chest, funnel chest, and also note for scars and lesions. Identify the apex beat, which is located at the 5th intercostal space midclavicular line on the left. Also note for hips, thrills, lifts, and abnormal pulsations by palpating the second right interspace, the second left interspace, along the sternal border, and at the apex of the heart. So to palpate hips and lifts, use palm of or hold your finger pads flat or obliquely against the chest. Hips and lifts are sustained impulses that rhythmically lift your fingers. So usually they are produced by an enlarged right or left ventricle or atrium and by ventricular aneurysms. For thrills, press the ball of your hand firmly on the chest to check for a buzzing or vibratory sensation caused by underlying turbulent flow. If present, auscultate the same area for murmurs, and the presence of thrills changes the grading of the. Next is to palpate impulses from the right ventricle. In the right ventricular area, at the lower left sternal border, and in the subxiphoid area. Next is to palpate S1 and S2 using firm pressure. Place your right hand on the chest wall with your left index and middle fingers. Palpate the carotid stroke to identify S1 and S2 just before and just after the upstroke. So for S3 and S4, apply lighter pressure at the cardiac apex to detect the pressure of any extra movements. The next part is for the hepatojugular reflex. Palpate for the liver, then put pressure for 10 seconds to elicit hepatojugular reflex. After that, you should measure the JVP right away. And at the last part is to palpate the legs and arms for edema. So the possible findings are normal shape of chest, a dynamic precordium, no hips, thrills, or lifts. Apex is at the 5th intercostal space midclavicular line on the left side. And JVP after eliciting the hepatojugular reflex must be higher than the previous measurement, and extremities are not edematous.
Ako po si Steven Arthur Baluya, second year medical student. Check ko lang po yung inyong dibdib at inyong paghinga. Kung pwede po sana, pakihingan ko lang po yung pulso. Tignan ko lang po yung pulso. So first, we'll assess for the respiratory rate by asking the patient that by telling the patient that we will assess his pulse rate. But we will actually observe his chest rise as he is distracted by us taking his pulse. So when assessing for his respiratory rate, you do the same for 1 minute, and you assess for his rate, effort of breathing, and the rhythm of his breathing. So pwede po sana tanggalin po ninyo ang inyong damit sa pagtaas. Tama po. Okay. First, you must, meron po bang nararamdaman sa akin?
Wala naman.
You must first identify any traces of tenderness by asking the patient if there are any, if he's feeling any pain in any area. Then you must assess if there's any bruising or any visible sinus tracts or cyanosis or skin changes. Next is, you must assess for chest expansion. Sir, tingnan ko lang po ang inyong ang paggalaw ng dibdib niya habang humihinga. So you must put both hands upon his chest with the thumbs along the costal margin with the space of one skin fold in between, and your hands upon his the lateral rib cage. Now you ask the patient to inhale, and you'll observe the movement of your thumbs. Sir, hinga po malalim. Isa po. Now your expected changes here is that your thumbs are supposed to, the distance between your thumbs is supposed to increase as the patient breathes in, and the distance is supposed to close as he breathes out. So next we'll assess for tactile firmitude. You must first compare both sides of the chest by using the ball or ulnar surface of your palms on specified points. Now, you'll ask the patient to say the word tres as you have your hands upon specified points laid out in the video. So, sir, pakisabi po ng tres pag i-instruct. Sir, sige po.
Tres.
Okay. Point number 1. Then another one, point number 2. Sir, sige po.
Tres.
Point number 2. Then point number 3 is on the sides. Sir, sige po.
Tres.
Okay. You must note the vibrations that he makes and if they are if both sides of the chest have vibrations as he's speaking. I'll now palpate the posterior aspect of the patient's chest by first instructing him to turn around. Sir, pwede po i-check ko lang po yung likod niyo. Okay. Ideally, you will do the same, but it will be modified for the back. So first, start with chest expansion. Chest expansion is assessed by having both your thumbs around the level of the 10th rib. Wait, oh shit. Yeah, this is right. Damn, retard. So you must also have the same skin fold, the same distance between the two thumbs, with one skin fold in between, and both hands are supposed to be at the lateral ribs. Now you will instruct the patient to inhale, and as that happens, you will notice the distance between your thumbs. Sir, hinga po malalim. Isa pa po. Notice that your thumbs will, the distance between your thumbs will increase in distance as he inhales, and the opposite happens when he exhales. Then we'll assess for tactile firmitude by again using your palm, the ulnar aspect of your palms on specified points that here laid out. The word that the patient will have to say is tres, and he will do so as instructed with your palms on the specified points. Sir, pakisabi po.
Tres.
Point number 2, point number 3,
Tres.
and then point number 4.
Tres.
The next step will be percussion, which is after palpation. Remember that you'll be using your third digit of your non-dominant hand, which will be the pleximeter, which will be in contact with the patient, and will be struck by the dominant hand, also known as the flexor, using the third digit as well. Now, first ask the patient if you can assess the vibrations of his chest. Sir, tingnan ko lang po yung dibdib niyo. Kung gagawin na po, gagawin yung kamay ko. Then you assess the patient, the vibrations of his chest in the method as demonstrated in this fashion. Third digit on the designated point with your right or the flexor striking the pleximeter on the distal interphalangeal joint as follows. Then it is shown like this again. Okay. You must do the same on the other side to see if there's any discrepancies. Then the next point you'll assess following the ladder pattern will be below that. Make sure that you are checking in between the ribs, or also known as the intercostal spaces. That way the vibrations are more obvious and they actually there are differences that are actually felt. So again, okay. Then, okay. Again, you go lower. This time on the side below that, and then you do the same. Make sure your hands are perpendicular. You will also do percussions on the posterior side of the patient, the posterior chest of the patient, and it will be on designated points in the same fashion as the anterior. So, again, perpendicular, distal interphalangeal joint. Then follow the ladder pattern. Follow that. The last step will be auscultation, and you'll be using your stethoscope, specifically the diaphragm. It will be at the same points of contact as your percussion. So first it will be done with the patient breathing normally. Sir, hinga po ng ganun. Hinga mo lang. Hinga mo lang. They will also do the same auscultations on the back with the same points of contact as your percussion. So this one is done in normal breathing. So, sorry naman natin. Okay. I will begin auscultations for bronchophony by asking the patient to speak the words 99 when you have your stethoscope, the diaphragm, on designated points of contact upon the patient. Sir, pag nalagay ko po yung stethoscope po sa dibdib niyo, sabihin niyo lang po yung salita 99. Tatlong beses po siya mangyayari. So, first will be trachea. Sir,
99.
Next will be your sternal angle.
99.
And then the last point will be at the apex of the left lung. Sir,
99.
Do the same for egophony. And then you'll ask the patient to speak the words, the phrase EE. Again, that's EE. Sir, sabihin niyo po ang EE kapag nalagay ko po ang stethoscope sa inyo. Same points of contact as the first one. So, trachea, EE. Sternal angle,
E.
left base.
E.
Again, the left apex of the left lung. Okay. Now, the last one will be for pectorality. And then you ask the patient to say 1, 2, 3 when you have your stethoscope upon the patient. So, sir, may sabi po 1, 2, 3. So, whisper 1, 2, 3 kapag nandun po ang stethoscope. So, same points of contact. Trachea. Sir.
1, 2, 3.
Sternal angle.
1, 2, 3.
And then apex. Okay.
Enumerate mo na lang sa likod. Tapos here are yours for the back, and that's it. And do the same.
Okay, so you will also do the same for posterior, and it will be on the same points of contact with the same test. So for bronchophony, it's 99. So pakisabi po 99, kapag nandun po ang stethoscope.
99,
Okay, so the angle,
99,
there.
99.
Okay. The next will be for echophony, and the phrase will be E. And you have the same points of contact. So sir, pakisabi mo E.
E, E.
The last one will be for pectorality, and the patient will have to say 1, 2, 3. We'll have to whisper 1, 2, 3. Same points of contact, so